did you say 40?
Yeah.
Like 40.
Let's jump forward. ASCO 2025, we saw DB09. So that was our first look at that data. We certainly saw the two arms, the trastuzumab deruxtecan pertuzumab arm compared to the standard of care CLEOPATRA arm. And certainly that amazing median progression-free survival over 40 months there. Talk me through that trial, maybe what your initial thoughts were.
Yeah, so I will tell you I thought it was incredibly impactful to see a hazard ratio in the first-line setting after a median follow-up of only 29 months, little over 2 years, to see that hazard ratio of 0.56. Very, very impressive. I think, as you mentioned, there were 3 arms to that study. Yeah. So I think we still await the results about, is T-DXd alone certainly a reasonable option? We do know that pertuzumab does add toxicity, and I think it's incredible also to have seen that not only overall response rates were improved, but complete responses were also improved, nearly 14%.
It was like
so again, that's a real important outcome because the depth of a response in the first line setting may correlate with setting up the stage for what could be a much more impressive overall survival than we saw with CLEOPATRA. I think that's what we're all hoping to see, especially as we start to sequence more and more options.
Dare we say cure for any of these patients, of course, is the exciting thing. And how did you describe the shift to your colleagues?
I think, when I first heard the number, I mean, we sort of all anticipated it was going to be positive. Sure. We've seen what T-DXd has been able to do, and it's really been a game changer, drug for us. So we all sort of anticipated it was going to be positive. When I first heard the number, 40 months, I literally said, did you say 40?
Yeah.
Like 40. I think that is just, I mean, just to think about talking about that with patients is really amazing. And as you mentioned, about 15% of patients, maybe 1 out of every 6 or so, getting a complete response with metastatic disease. I mean, that to me is just, that is so very exciting. And
we were so excited about CLEOPATRA.
Right.
And then the magnitude of that benefit.
Right, absolutely. And to think about that, some of these patients, might actually be cured, is really exciting, obviously.
So let's move into the clinic. It's Monday morning, your first patient's coming in with this option. Are you starting all patients on DB09? Which patients, I think, are you moving to DB09 now, given this data?
So I think there's still a framework in my mind. I don't think that I'm collectively offering it to all, but I am thinking through, what was their first treatment like? How quickly did they progress? After, are they a de novo patient? How much visceral disease do they have? Do they have oligometastatic disease? Do they have 2 or 3 bone mets only? I take into consideration their ER and PR positivity, negativity into the equation. Certainly, brain metastases is very important if they do have it up front. I think that I am going to be favoring the T-DXd pertuzumab regimen on those patients, as we've seen a collective amount of data supporting T-DXd and its impact in central nervous system control. So those are all things that I will be taken into consideration. I think I will lean towards the T-DXd pertuzumab, but really in a group in which the CLEOPATRA still fits in a suiting. I think, like all of us think through, as comorbidities and performance status too. I think that all has to be taken into consideration as I think through taxane versus T-DXd.